fads in medicine. That's not to say that fads don't work, but it'd be nice to know that they do before you expose, say, your sore, stiff knee to a procedure and your bank account to the bill. One such popular treatment is platelet-rich plasma injections, where the doctor or a company or a nurse takes your blood, spins it down and injects the plasma, the yellow fluid on top, into your knee joint. It's touted to relieve the symptoms of osteoarthritis and perhaps even delay or avoid knee replacement surgery. A group of Australian researchers has just published a randomised clinical trial of platelet-rich plasma injections in knee osteoarthritis. They published in the Journal of the American Medical Association. One of the authors was David Hunter, who's Professor of Rheumatology at the University of Sydney and an old friend of the Health Report. David, welcome back.
Thanks very much for having me along, Norman.
What's the theory behind this plasma?
The platelet enrichment is thought to contain a number of growth factors that are helpful for repair of joint and other tissues, and that's the underlying theory as to why it may work.
Right. I thought it was irritation. So, physical irritation is what some people thought happened.
There are some variations of platelet-rich plasma which have more white cell count, more greater leukocyte numbers, and by virtue of that, it can also cause inflammation. Some of the growth factors are also thought to lead to a short-term inflammation and hence repair. But again, this is really needs to be tested properly.
Now, I've heard of orthopaedic surgeons taking the blood, spinning it down in the office and then re-injecting it back in, but there are also commercial products available.
There are a number of companies that are involved in this space that are selling kits that allow this to be done in the clinic and allow the blood to be spun down and then re-injected. And so that's actually a big business.
How big?
The last estimate that I saw, Norman, from about 2 years ago in the US was in the order of about $200 million per year just in the US, and it was growing at about 10 to 15% a year.
And how often do you get the injections and what do they knock you back?
The number of injections varies by the proprietary product, but in general it's somewhere in the range of 3 to 5 injections given weekly. And the typical cost of these, again, varies a little bit depending upon who's administering it, but can range anywhere from $500 an injection up to $2,000 an injection.
And what was the evidence that it worked before you did the trial?
So the number of randomised trials that are out there that I would categorise as not optimal quality, primarily because they had poor blinding either of the participants in the study or the assessors, hence some of them knew what they were receiving. And in those trials, there was actually a strong suggestion of a positive effect from platelet-rich plasma. But unfortunately, there hadn't been a rigorous trial done to date until we conducted ours.
And what did you do in your trial?
We recruited 288 people with painful knee osteoarthritis and randomised them to either saltwater injections or platelet-rich plasma, PRP injections, which were given weekly over 3 weeks. And then we followed these people out for 12 months and monitored their pain and also looked at cartilage thickness on an MRI. And at the end of that 12-month period, there is no clinically meaningful or statistical difference in either their pain or their MRI structure.
From placebo, did you get a difference in pain overall?
There was a difference in pain. So this is pain measured on a 0 to 10 scale. And what we saw in both groups was a 2-unit improvement approximately. But again, no meaningful difference between the two treatment groups. So there is a placebo effect, which we know is quite strong in injection trials in knee osteoarthritis that we did demonstrate in this trial as well.
Any complications?
We didn't see any meaningful or significant adverse effects related to this, but anytime you stick a needle in a joint, you do run the risk of introducing an infection, which is the underlying concern that we were worried about, but we did not see that in the 288 people we recruited.
So story over?
This is one particular modality of delivering platelet-rich plasma, and most of the criticism that's come our way by virtue of regenerative medicine specialists since the trial has been published is that there are other preparations out there that are thought to be better. But I guess I would charge them with coming up with evidence, because at the present time, they don't have good evidence to substantiate their comments. So at least from my perspective, platelet-rich plasma is not something I'm going to be advocating people with osteoarthritis receive.
It's like the old story with glucosamine, where one particular manufacturer said their product was much better than the others, but there probably wasn't any difference in the end.
Yeah, I mean, there are lots of stories like this in osteoarthritis, as you well know, Norman, with arthroscopy, opioids, where there's been strong vogue towards wanting to use different types of treatments, but unfortunately the trial's not substantiating using these particular types of treatment.
It's a shame, because it'd be nice if it did work and prevent unnecessary surgery.
Well, I think from the perspective of people who have painful knee osteoarthritis, they're desperately looking for treatments, and so pain at present is a large unmet need. But there is a lot that they can do with regards exercise, remaining active, and if they're above a healthy weight, losing weight. But this is one of a number of therapies that we're finding out in trials at present that are probably not necessarily standing up to muster.
Now, the other one that's being used in some orthopaedic surgeons' offices and also rheumatologists is stem cell injections.
Exactly. So again, they appear to be quite widely used, appear to be quite expensive, and at present the best evidence doesn't necessarily advocate for its use. We're currently conducting a study looking at the use of intra-articular stem cell injections, and again monitoring people's pain and structure on MRI. And that's a study called the Sculptor study or Sculptor trial, and it's been conducted at Sydney and in Hobart. And as we say, we're recruiting for that trial at the moment. So if you look for the Sculptor study or Sculptor trial, you should be able to find that.
So it's open for business, and we'll put that link on our website. So nothing much new in osteoarthritis then, apart from weight-bearing exercise, keeping your quads strong and looking after the pain a bit.
It's an exciting time to be involved, Norman, because there's lots of people out there who haven't been as active during the lockdown as they could have been. And so we're actually seeing a lot of people who need a lot of help. But I think it's actually quite exciting, because there's a lot of what we call disease-modifying therapies being developed that modify both structure and symptoms, that are in late-stage phase 3 trials, which I think will lead to dramatic changes in care within the next 3 to 5 years.
Well, we'll get you back on. David, thanks for joining us.
Thanks so much for having me along.
And we'll have the details of that trial, as I said, on our website. David Hunter is Professor of Rheumatology at the University of Sydney.